Okay. So I'm just going to go through this presentation. It's a systemic review and meta-analysis I did about 2 years ago. It was looking at ways of lowering the cost of IVF, comparing the conventional and with possible cost-cutting strategies. Down. Okay. So the background is simple and pretty well understandable to all of us. Conventional IVF is expensive and is beyond the reach of many people, both in private and in public. The aim was to develop or to understand methods of lowering the cost of IVF with particular emphasis on resource-constrained setups. So the cost drivers in conventional IVF are clear. Number one and foremost is the infrastructure and equipment, and then we go to investigative procedures, and then the laboratory equipment, consumables, the drugs used in cycle manipulations, and also the complications. So what possible strategies can we use to lower costs? Number one is simplifying investigations, lowering the cost of ovarian stimulation, using simple laboratory equipment and procedures, using nurse-led units, and also trying to lower the complications. So simplifying ovarian stimulation is probably the lowest hanging fruit. And ways of simplifying it have been tried since time immemorial. In fact, as the fertility specialists who can allude to, when IVF started, they were using natural cycles, meaning no stimulation at all. Obviously, there was the disadvantages of poorer outcomes, but the methods available could be a natural cycle, modified natural cycle IVF. I will expand a bit later in those mechanisms. And then mild stimulation IVF techniques, sometimes called minimal stimulation IVF. And then further decrease can be achieved by targeting various approaches, especially when you're trying to suppress premature ovulation. Instead of using GnRH antagonists, you can use non-steroidal anti-inflammatory drugs or low-dose clomiphene or oral progestins. So the International Society for Mild Approaches in Assisted Reproduction came up with those definitions. The natural cycle IVF is the one where there's no medication at all, and it uses a single egg. So even all the pioneering or the origins of IVF use the natural cycle, but it's got the disadvantage of premature ovulation, and dealing with one oocyte, the likelihood of success is very low. Then modified natural cycle IVF is almost natural cycle, but there's a bit of manipulation. The manipulation would come at the point of triggering, where HSG is given to mature the follicle, to mature the oocyte, or sometimes you can have a bit of add-back therapy in terms of SH, just minimal support. And then mild IVF typically uses doses less than 150 international units of FSH or HMG. And sometimes it uses oral compounds, clomiphene or letrozole. And it can use also GnRH antagonists to prevent premature ovulation, or it can use those other agents which I have mentioned previously. And then, of course, conventional IVF is one which gives you the highest yield of oocytes, and typically is using the GnRH agonist or the antagonists, and using the doses which are above 150 international units of gonadotrophin. So there's been the Working Egg Project initiated by Prof. Omblet. They founded this in 2010, and they were advocating for simplifying investigative procedures, and then also simplifying IVF laboratory procedures and stimulation protocols. So in this systemic review and meta-analysis, I looked at studies done after the year 2000, and the search strategy looked at databases, Medlines, Central, Cochrane, PubMed, Embase, and also clinical trials registry. I also did snowballing from reference lists of other studies. And then I abstracted data onto an Excel spreadsheet, and then afterwards, I did meta-analysis using Review Manager. So I used the PICO strategy. In fact, this PICO's here, where our population were women selected for IVF, and then the interventions were cheaper IVF investigations, cheaper embryology laboratory techniques, natural cycle IVF, mild stimulation, low-cost IVF, egg sharing, and nestled units. And then comparator was mainly conventional controlled ovarian hyperstimulation, but I also did compare with other the various regimes of mild IVF or modified natural cycle IVF. The outcome was mainly live birth rate, pregnancy rate, and time to pregnancy. And all studies between January 2000 and August 2022. We're looking mainly at clinical trials, but we had some observational studies in the form of cohort studies. So the outcome measures, clinical pregnancy rate was clinical pregnancy rate per cycle was any pregnancy confirmed by serum beta hCG and a gestational cycle 6 weeks. Ongoing pregnancy was a pregnancy which had fit out at 12 weeks post-embryo transfer. Live birth rate per cycle was defined as babies delivering at a viable gestation were conceived from one cycle of IVF. And then cumulative clinical pregnancy rate, ongoing pregnancy rate, and live birth rate were referred as the total number of pregnancies per defined period or per number of cycles. So clinical pregnancy rate, ongoing pregnancy rate, and live birth rate could be used in the systemic review. I use them interchangeably because they tended to reflect the same thing, or they can be a proxy of each other. And the definition was essential because there tended to be variations in the way they were being defined in the various sources. So in terms of the results, so after inputting my search item, obtained almost 98 studies, and going through the various rounds of screening, ended up with 38 studies which are eligible for analysis. We had 11 studies. We looked at mild stimulation in women's good ovarian reserve, and then mild stimulation in women's poor ovarian reserve were 10 studies, and then also looked at embryo transfer studies, the ones which are comparing conventional and modifying natural cycles, which had 6 studies. So I'll just look at these charts, and as you can see, these particular studies are comparing mild versus conventional controlled ovarian hyperstimulation in women with good ovarian reserve, and looking at clinical pregnancy rate, ongoing pregnancy rate, or live birth rate per cycle. We're just treating them as one thing. Only 4 studies were eventually analyzed. There were reasons why I dropped this study by Ochin. It really had so many biases in it, so eventually didn't use it for the final evaluation. But as you can see, when you look at this odds ratio, it was 0.61, meaning there was less or reduced outcome when you use mild IVF, meaning conventional controlled ovarian stimulation had better outcomes in women with good ovarian reserve. Then the next analysis, almost similar again, mild versus controlled ovarian hyperstimulation in good ovarian reserve women. We're now looking at the cumulative life birth rate. So this is really following up for having women either over many cycles or over a defined period. And again, the mild IVF tended to have reduced outcomes, though this was not quite statistically significant because we can see one is just appearing there, and this effect measure is almost touching the line of no effect. Then when I looked at the studies, so, when I looked at the side which compared mild versus controlled ovarian hyperstimulation in poor ovarian reserve women, you can see all the studies were almost centered around the line of no effect, and even the summary effect measure was sitting perfectly on this line, and the odd ratio was a perfect one. So there was no difference between mild and controlled ovarian hyperstimulation in women with poor ovarian reserve. When looking at natural cycle and modified natural cycle IVF versus conventional ovarian hyperstimulation in poor ovarian reserve, again, there was no statistical significance, but these were only two studies which were analyzed. The one by Polizos, it also many biases, so I eliminated it from the overall analysis. So, but there seemed not to be any advantage of using either conventional controlled ovarian hyperstimulation over natural cycle or modified natural cycle IVF. As I mentioned earlier, the overall outcomes were very low, both for controlled ovarian hyperstimulation and for mild stimulation. And then when looked at natural cycle or modified natural cycle frozen embryo transfer, comparing with the artificial cycle. So for frozen embryo transfer, commonly the artificial cycles where the cycle will begin by the woman getting estrogen from day 2, and then when the endometrium is reached a certain stage, then they get progesterone. But there's an option of just using a natural cycle where the cycle is monitored to ovulation, and then the corpus luteum now will provide the luteal phase support. Of course, the disadvantage of again of failing to predict the time of ovulation. With modified natural cycle, they will then give a trigger to make sure they can time when the corpus luteum is going to form. So these comparisons, again, they're almost all close to the line of no effect, but this study did suggest that natural cycle was having a slightly better effect than the artificial cycle. So I looked at laboratory embryology techniques. There was intravaginal culture of oocytes in vivo, which is a membrane which is put in the vagina after the embryos have been put there. This one had a live birth rate of 55% compared to 60% for conventional culture. Then the simplified culture system had the ongoing pregnancy rate of 30% versus 36.7 for intracytoplasmic sperm injection. Again, these were only two studies, so and there was really, it was also not possible to do a meta-analysis of them. They were very heterogeneous. So this systemic review and meta-analysis showed the equivalent outcomes for mild stimulation versus conventional controlled ovarian hyperstimulation in poor ovarian reserve women. So what it tends to suggest is that the poor ovarian reserve or the ovarian reserve tends to be the rate limiting state in these women, and it won't respond to any higher dose of ovarian stimulation. This agreement was in finding by other systemic reviews, one by Data in 2021 and Song in 2016, which found no difference in pregnant rates between mild stimulation and controlled conventional ovarian hyperstimulation. The practice committee of the American Society of Reproductive Medicine, in their guideline, also did not see a difference in clinical pregnancy rate between mild stimulation and conventional controlled hyperstimulation in poor ovarian reserve women. However, Polizos et al. Had a different opinion. They did not agree to women with poor ovarian reserve being treated as a group. They wanted them to be individualized, and argued against universal adoption for mild stimulation in poor ovarian reserve. So what's important to note, natural cycle or modified natural cycle is a very low success rate. 6.1 to 13.7% in the studies here. Though, however, there was no difference when you're comparing conventional controlled hyperstimulation in this review. A study which had been done by Pelling earlier on shown a clinical pregnancy rate of 7.9% and a cumulative life birth rate of 44.4% after 9 cycles. So if you're saying at one cycle it was 7.9%, and then you have to repeat it to eventually have a live birth rate of 44.7 after 9 cycles. But that's lots of intervention and lots of discomfort and probably lots of cumulative costs to the patient. So one can argue that this method is probably not lowering the cost of IVF. And then when you go to the natural cycle or modified natural cycle frozen embryo transfer, while it seemed superior to artificial cycle frozen embryo transfer, they didn't do a cost-effective analysis. So what you notice that in natural cycle, there's lots of monitoring. So the inconvenience of monitoring to see how the oocyte is delivering to baby time to time at the time of ovulation might counteract or might even increase the costs and the inconvenience to the client. So the raging debate, which is always there, is between low cost versus conventional IV. Some will say let it be offered because it's the only option available. Some will say it's unethical to give people an intervention which you know is less efficacious. So I did conclude that this debate, it must be viewed in terms of having some service to offer where no other option exists, rather than the viewpoint of giving some clients a less efficacious modality of treatment. In fact, that's really the contentious issue. Why should a group of women, because they are poor, get a less efficacious modality of treatment versus just giving the real thing? Then again, an assumption is made that lowering the entry cost of IVF improves access to those who could not have considered regardless of the outcomes. In one study, they actually showed even if you try to lower the cost of IVF, it still remained out of reach for the majority of the population. Again, there's a debate of which pregnancy rate would justify the IVF intervention. And again, eventually it ends up with the preference of that couple. Some, even if they are told that your chances are 10%, they will still go for it. So in conclusion, in vitro fertilization can be made cheaper by adopting mild stimulation, natural cycle or modified natural cycle stimulating protocols for women with poor ovarian reserve. There seems to be an overwhelming agreement that in poor ovarian reserve, there is no difference in outcomes. For women with good ovarian reserve who cannot afford controlled ovarian hyperstimulation, protocols should be offered for them to have these other milder forms of stimulation. Studies must explore every step in IVF to assess cost effectiveness to adopt method with the most minimum cost. So you should appreciate that at the onset of this study, wanted to look at multiple angles of lowering the cost of IVF. But the only one which could find in the studies were to do mainly simplifying stimulation. The other possible angles have not been studied conclusively. So I think that's the conclusion. Thank you.